Hello, and welcome to the New Jersey Healthcare Quality Institute's Winter Conference. It's so great to see the numbers growing in the participant box, and I wish we could all be together, but we really are excited about the lineup we have for you today and the great participation we have in the registration. So we know that even though we won't be together in person, we've got a great afternoon in store for all of us. My name is Linda Schwimmer. If I haven't met you before, I'm the president and CEO of the New Jersey Healthcare Quality Institute. And I really wanted to start today by giving a few special thanks. First, I want to give a thanks to our staff who not only put together today's conference, but really for all the work that you do for the Quality Institute, for our members, and for our board throughout the year. We really could not do all the work we do and accomplish what we do without all of you and your dedication. I also want to thank our board of directors and our leadership council. We rely on all of you for your guidance and your deep experience and your thought leadership as we work together to improve the quality, safety, and affordability of healthcare for everyone. And I want to thank our members. Many of you are on today, and we appreciate your engagement. The fact that we have such a very multi-stakeholder membership is really one of our unique qualities and our strength. You bring so many different perspectives to all of the topics that we discuss and so much of our work. And so thank you for your contributions and support and engagement with us. And if you're on today and you're participating in this conference and you're not a member of the Quality Institute, what are you waiting for? We would love to hear from you. We would love to find out more about you and your organization and see how we can work together on our common goals. So we will be looking forward to hearing from you. I also want to share some good news with you that the Quality Institute is growing. We have 2 new staff members. I wrote about them in my last blog, but here they are on the screen for you. Armenie Pierre-Jacques, who joins us, she's a TCNJ alum and also got her MPH from Drexel. And Armenie is going to be working with us on many of our policy initiatives, as well as our 2 community health projects, specifically our Mayor's Wellness Campaign and our COIL campaign, or Conversation of Your Life. And I'm also really thrilled to welcome Katie Bishaha. Katie comes to us directly from a longstanding experience at a family success center supporting individuals with services related to substance use, as well as nutrition and food security programs. And Katie is also an NJ grad. She is a Montclair State alum. So welcome to both of them. I hope that you all get to work with them and meet with them over the next few months. Now I want to share a couple housekeeping items. You're probably used to these by now, but I'll go through them. The presentation is being recorded. A copy will be shared with all of the attendees and others shortly after this event. All phone lines have been muted for the duration of the program to limit background noise, but we do encourage your participation in the chat throughout the event, particularly towards the end of both the keynote speaker and the panel. We're hoping that you will chat in your questions or comments, and that if you do want to be unmuted and actually verbally share a thought or question, just raise the raise hand in the symbol in the webinar, and we will do our best to unmute you and get to your question. And now I'm going to move on to the topic for today's conference. So that topic is primary care as a common good, the prescription for a healthier and more equitable healthcare system. In April 2021, many of you will recall that the Quality Institute, in partnership with BioNJ, and many of you, in fact, probably most of you, released a report called Emerging from COVID-19, an action plan for a healthier state. That plan created 24 consensus recommendations on how to guide healthcare policy leaders and others to drive best practices and solutions informed by the experience of New Jersey healthcare leaders during the COVID-19 pandemic. And in that report, recommendations 14, 15, and 16 all focused on strengthening patient access and connection to high quality primary care, as well as improving connections between public health and primary care. We know that strong connections to primary care improve health outcomes for patients, improve equity, and improve the overall health of our healthcare system. We know that this was a big issue during the pandemic, and that is why we chose to focus our conference on this important topic of implementing and supporting a high quality primary care system. We will also be continuing this conversation later into 2022. We have a part 2 to this series because there really is a lot to talk about when it comes to implementing higher quality primary care. And I see we already have the sneak peek for that one. Just as our format is today, we will have a keynote speaker followed by a multi-stakeholder panel. And the keynote speaker then will be Chris Kohler, who is president of the Milbank Memorial Fund. And he is one of Professor Hudson's co-authors on the National Academy of Science and Medicine report. So we're looking forward to that. That's going to be on February 23rd. But sticking to today and the star of our show today, I am really excited to introduce to you Professor Shauna Hudson. Professor Hudson is a professor. She's Research Division Chair and Henry Rutgers Chair of Family Medicine and Community Health, and founding director of the Center for Advancing Research and Evaluation for Patient-Centered Care at the Rutgers Robert Wood Johnson Medical School. She's a community engaged primary care researcher working with vulnerable populations at the intersections of community health, primary care, and specialty care. She's a medical sociologist, which you don't get to meet every single day, a medical sociologist, but I'm certainly glad that we met her. And she was one of the co-authors of the somewhat recently released, report out of the National Academies of Sciences, Engineering, and Medicine's Committee on Implementing High Quality Primary Care. And that is what she's speaking with us today. So at this time, I'd like to welcome Professor Hudson. She's going to give her presentation, and then we decided that rather than having a long presentation, we are going to have an engaging conversation about all of this work, and then we want you all to jump in with your questions. So Professor Hudson, it is great to see you, and I will leave it to you at this point. Thank you.
That's great. Thanks for such a fantastic introduction, Linda. Let's see if I can get the slides to go up on my side and share. Do we all see them? This looks good on my end. So
Yes.
what I wanted to do this afternoon, just for about 10 minutes or so, is to just give you some context for the report, Implementing High Quality Primary Care. And so as Linda had mentioned, the report came out this summer, back in June. There were about 20 members who were on the panel, and we were a wide variety of different disciplines that were represented, ranging from physicians, nurses, dental professionals, a pharmacist. There was a physician's assistant. We had economists, anthropologists, myself, a sociologist, and as well a director of a community health worker program. So a wide variety of perspectives on primary care, and really focused in on how do we sort of think about primary, how do we see it now, but more importantly, how do we want to see it built for the future? Let's see if I can advance the slides. Here we go. So just to give you a sense of what our statement of task was for the project, we were basically charged with looking at the 1996 Institute of Medicine report, Primary Care, America's Health for the New Era, and to look at developing an implementation plan for that particular work. What we ended up doing was that we looked at developing the implementation plan, and our committee considered a number of different issues and felt that our goal needed to be both bold as well as pragmatic, and especially in terms of the areas of payment, which Chris Kohler is going to be talking about in the new year. We really were focused around sort of what is it that we can do now, and then what are the systems that we need to have in place to really set things up and move them forward. So I want to give you a little bit of context for the study. As all of you know on this call, primary care is probably the only part of our healthcare system on a population level that produces longer lives and more equity. And so with COVID-19, one of the things that we found was really that it brought to light longstanding health inequities, made them more visible, and likewise how important it really sort of brought into focus how important primary care is in the United States. We have a number of different systems here across the world where we've seen comprehensive primary care and person-centered approaches really working well. But within the US, we see that primary care is highly under-resourced financially and really lacks a unified voice. And so it was really within that context that we started to look at primary care and to think about how do we now strengthen it. In addition, as you can see from this slide, primary care makes up about 35% of our services, but only 5% of our expenditures. And so expenditures in this particular graph are really direct payments for care that include those that are out of pocket. And primary care in this context is really care being provided by our family medicine, general practice, geriatrics, internal medicine, and as well general pediatrics colleagues. So when we looked at that context, and then we also thought about the underinvestment that we have in terms of health inequity and the financial pressures that we see in our practices that are bearing down upon our clinicians, the burnout that we have, suboptimal care, and then also COVID-19 really amplifying a lot of the social ills that we already are seeing within context. Primary care really has not had a champion in the ways that some other areas have had. And it's also in many ways feeling some of the similar pressures that small businesses have felt with reductions in visits and then therefore payments. And so we're really sort of looking at the context of COVID and then also the issues around primary care and trying to figure out sort of how do we move forward in the next phase of this. So what we were tasked to do was to come up with an updated definition of primary care. And in that updated definition, what we wanted to do was to make sure that it actually reflected a new focus on the importance of communities, on the diversity of settings that we have that are actually providing primary care and the different modalities to provide primary care. And then also thinking about the ways in which we actually get to high quality primary care. So the use of our interprofessional teams and the need for primary care to be equitable. And so our updated definition really, we wanted to make sure that all of those components were really highlighted and brought to bear there. The committee felt very strongly, and so the title of our session today is Primary Care as a Common Good. But the committee as well thought that primary care should be really considered a societal value, and that its role in health equity is really important and therefore should be considered a common good, which is really accessible to everyone. The goal of our implementation plan is really to sort of think about how do we elevate primary care to common good status and to give it the supports that it needs and that our country needs in order to get there. So with the report, there were 5 major areas that it sort of focuses on. The first one is payment. The second one is access. The third area is workforce. The fourth, digital health. And the fifth is really accountability. And what I'm going to be focusing in on my comments today is really in the area of the second piece, which is access. And so when we think about access to care, and we really think about the pieces that are really important there, one of the major things that we wanted to do was to amplify that with high quality primary care being available to every individual in the country, that it implies a 3-way partnership between our patients, our teams, and our payers, and as well the government and all of those others to protect our vulnerable. So in terms of access, what I want to do in this section is just to sort of end where I think our discussion, my discussion with Linda is going to really begin, is to talk about sort of the concept of primary care as a common good. And so really, we know that primary care is foundational to the healthcare system and really critical for achieving health equity. And so in chapter 4 of the report, which is one of the major areas that I worked on, we talked a lot about the importance of moving to a person-centered, family-centered, and community-oriented form of primary care, and that really the importance of that. One of the ways that we got to thinking about that is that our committee did an open forum where we heard from patients and advocates and as well different community members who talked about what primary care means to them and more importantly, how can we better serve them? And so through our review of the literature and as well listening to the voices of individuals and advocates, we really sort of came to a shared understanding that when more people have access to primary care, we have healthier populations and better, more equitable outcomes. And so for this reason, it's really why we decided to move towards this language of primary care as a common good that should be available to everyone, regardless of their insurance status. And so there were 5 actions that we talk about within the report that are really focused around how to increase access. The first one is really around universal empanelment. And so we'll do a little bit of talking about that in this next section. But for us, in terms of the report and the text of the report, we felt that all individuals should have an opportunity to have a usual source of primary care and an ongoing relationship with their primary care. So for payers, this means that for anyone who is a covered individual, that they should declare their usual source of primary care on a yearly basis. And for people who are not responding in terms of the enrollees, have methods to actually track that information and then use payment to address sort of accountability measures. For the uninsured, particularly in the settings where they seek care, like our healthcare centers or hospitals, and also in primary care practices, that we actually need to assume responsibility and document ongoing clinical relationships with people where they're being treated. So that's sort of the first action. The second action was really around and leads into the second action, which is supporting the underserved. And here the report really recommends that HHS target sustained investment in the creation of new healthcare centers in federally designated workforce shortage areas. And so this would include increasing federally qualified healthcare centers and other lookalikes, and as well school-based healthcare clinics, rural health clinics, and then also providing resources for IHS, the Indian Health Services. In terms of the other three remaining actions underneath access, the third one is really around improving access, and it focuses in on Medicaid beneficiaries and recommends that CMS revise and enforce its fee-for-service and managed care access standards for primary care, ensuring that there is adequate access, and then provide technical assistance resources to our state's Medicaid agencies, so that there are resources there to help with implementing and attaining the standards, and as well ways to measure and publish how the states perform. In terms of the fourth action under access, we talked about really having it support equity by permanently supporting the COVID era rule revisions and some of the Medicaid and Medicare benefits interpretations that have facilitated our team-based care methods and approaches. And so we've seen that there's been more equitable access to telephone and virtual visits, that there was some easing of the payment, as well as the payment for non-in-person visits, and as well easing some of that documentation and those requirements. And we want to see those things that were adopted during COVID be permanent as opposed to sort of transitory. And then in the fifth area here is really sort of where some of my work falls in, is around this issue of community co-creation and partnership building. We felt strongly that the literature, as well as what we were hearing from individuals, that primary care practices really need to move towards a community-oriented model of primary care. And when we talk about that, what we really mean is that we want to have community members who have lived experiences involved in the governances of our practices, in our practice design, and in our practice delivery. And some of the ways that we can do this is that we can work with our workforce to actually provide opportunities to partner with community-based organizations, and then make sure that our accrediting bodies are actually encouraging revising our standards to facilitate these changes, as well as bringing up our workforce from the communities that we actually serve. So with that, those are the sort of major pieces of the report that I wanted to just give a little overview of the work that we have been doing with the National Academies, and to sort of set the stage for, I think, the conversation that Linda and I will begin to have, and hopefully they'll be able to have with all of you as we engage with questions and answers during the different pieces. So I'll stop there.
So much, Professor Hudson. I really, yeah, that was great, and lots to talk about there in the report. For those of you who haven't had a chance to read it yet, at least even just the high level summaries of each section are there's a lot in there. So let's jump right in. As you mentioned at the very beginning, the COVID-19 pandemic really highlighted a lot of the social ills. And you mentioned that having a community-focused practice, a primary care practice, community connected, is one of the suggested ways to achieve better equity. I'm wondering if you could, if there are specific examples of how that's been, that you've seen that done successfully, either here in New Jersey or elsewhere, and some, I think, more specific suggestions. We do have a lot of primary care providers and researchers who are on the line today, so that I think that'd be helpful.
Sure. So I'm going to switch out of my role as a member of the committee and now switch into my role as a member of the New Jersey community to answer the questions. So, you know, it's been interesting during COVID. I think that, you know, we saw, particularly, we had a project that was funded by NIH to look at testing and then also vaccine distribution and inequities in our different communities, particularly the Black and Latino communities. And so some of the work that we did in that area, we actually found a lot of people had difficulty accessing some of the settings because primary care wasn't really engaged in the rollout of a lot of our COVID, both the testing early on and then as well some of the vaccine pieces. So I think now we have more access within primary care, but at the very beginning it was extremely difficult for particularly underserved populations to be able to get access through some of the larger settings that were just not community focused. So I think we've seen some partnerships with, particularly at least in New Brunswick. I know that our federally qualified healthcare center, Chandler, worked very closely with community organizations to be able to provide both vaccine as well as testing and others. I know that some of the federally qualifieds in other parts of the state have also been extremely active in terms of making sure that there's access. So that's been one of the sort of successes, I think, but it was something that happened much further on and wasn't immediately sort of the rollout for COVID, was that once we started to bring primary care into the fold, that then communities were opening up and we saw testing rates start to rise over the summer. And I think that was because we really had primary care engaged at that point in ways that we hadn't been at the very beginning of the rollouts.
Right. And I think that really speaks to one of the issues that is in your report, and it's definitely in our action plan, which is really how can we support connecting the public health system, whether it's at the state level, Department of Health, or the county or local public health offices, with primary care, because oftentimes there is a disconnect. But yet, right at this moment where there was a lot of misinformation, or even now where people really just have so many questions about what's safe and testing and boosters. By the way, today's Boost New Jersey Day, I have to say that.
Yes,
and
yes.
Encourage everyone to get their booster. Yes. But there's such a role for primary care physicians and nurses and providers of all sorts. There's such a role right there as trusted members of the healthcare system, but there has been this historic disconnect between public health and primary care. And some of that is, frankly, a lot of the very complicated systems that the state has. Any pediatrician will go on and on about our vaccination system. So I'm curious, besides the vaccination piece, what suggestions did the task force, or do you have for really, and I guess this goes to this issue of community-based primary care, but what are some suggestions where we can all work together to really bridge that divide?
So I will say that the committee didn't really deliberate on that topic, but one of the things that I have seen sort of happen over the summer and now move forward is one area that we did highlight was the role of community health workers in being able to help as a bridge for that. And so there's been funding that's come out of HHS within the last, I'd say, 6 months or so, where I know that the cities of Patterson and also Newark received large health literacy grants around COVID-19, and being able to really build a community health worker workforce that in some cases are embedded within primary care settings and then also embedded within community health settings. And so what's really nice about those models is that you have the opportunities to see sort of local groups that are working with the Department of Health to actually figure out sort of what does that curriculum look like around literacy, and then also partnering with primary care sites within those settings to actually be able to talk about, okay, if you have questions about testing, if you have questions about vaccine, or what do I do if I'm not feeling well? How do I get into primary care? That this is one of those places where we've been able to see some funding and then also see the different stakeholders working together around a solution-based approach to it. So I think there are some opportunities, and I'd love to see more things like that coming down the pike, because those opportunities really allow us to really maximize relationships where you've got community members who know their communities, primary care has been brought into the fold, and now we're actually helping individuals in a more person-centered way, rather than sort of thinking about you when you become a patient, but more proactively dealing with the issues of health and healthcare within our communities. So it's one of those areas where the report talked about the need for community health workers and really broadening our idea of what the healthcare team looks like beyond just our physicians and our nurses, who are extremely important, but we also need our social workers and our dental folks, and we also need our physician's assistants and others, and community health workers who are really addressing sort of broader picture issues of the community and how do people access care. So that's an example.
That's great. And I as much as sometimes we're critical of New Jersey because we're here and we're trying to prod it into doing more, I think that's one area where New Jersey and a lot of our members have really been leaders, whether it's through our regional health hubs or some of our Medicaid managed care and other health plans have been investing in this community health workers. So I think I'm glad that came up. And you raised oral health, so I'll jump there. I'm wondering, because that was one of the questions we already received, and folks, please start putting in questions into the chat, because I know we'll have time to get to them. But they're curious whether oral health and its role was included in the primary care discussion in the report. I was wondering if you could talk a little bit about that.
Sure. So we actually did have a member of the committee who is in oral health, and that was an area that was specifically called out in the report as needing more attention. So it is certainly in the report. And so, yes, it is definitely there and something that was recognized as being particularly important that needs to be addressed in terms of implementation.
Great. I'm going to switch gears a little bit because this is the part of the report that I'm fascinated by and would love to hear maybe some of the differing perspectives. And that's this issue of really the core issue of primary care as a common good and assigning everybody a primary care provider. That was something that was sort of part and parcel of the HMO trend a long time ago. And then there was a lot of pushback on that, and free range care was considered, something that was a positive, but that really led to, frankly, a lot of lack of coordination and duplication and cost. And I'm wondering, I'm sure this was all talked about, but the positives of this and why it's actually better for patients and communities.
Yeah, so I mean, one of the major pieces that we talk about in the report is the need to have a relationship, but we also tried not to define sort of, here's the traditional relationship. It has to just be the patient and their doctor. It's really about the connection with that healthcare setting, and also the larger team. And so it's really important to be able to have a place that knows you and knows who you are. And at different places within sort of the lifespan, that may be different parts of primary care. So for example, women who are of childbearing age, they may be more sort of connected with their OBGYNs, or kids with their pediatricians. And then as we get older and we age, it may be our general internists or our family physicians. And so, and then also with the different members on the team, because obviously we have nurse practitioners, we have physician's assistants and others that we see as we sort of come and go, but you want to have a place that actually knows you. And so, and that was sort of the key component to this whole issue around empanelment. And so we know different populations are accessing healthcare in different ways. And so that's why we really wanted to make sure that, and I think Chris will go into details on this when he comes and speaks later on, but it was really about individuals who have insurance. We want to make sure that they choose someone or something to have a relationship with. And for those who don't have insurance, that the places where people are actually seeking care then become responsible, at least for in that episode, for the care. But it's really about this whole need for relationships and relationship building, and that primary care is one of the few places where you sort of have the integration of all the different subspecialties. There's someone who's sort of looking holistically at you as an individual. And as a person, and being able to address the whole person issues as opposed to sort of the body systems and the different acute things that may be coming up. So that was really one of the major pieces that we talked about, and that was really important, I think, within this report, was the concept of relationships and having a core relationship that is part of primary care, and that is a common good.
And so for those folks that are reached out to, particularly, I think this is going to be the case for people in their 20s, let's say, people who are reached out to, but then never reach back,
Right.
Or people who are reached out to, but life gets in the way and there's a million barriers, or frankly, records aren't as good as they should be. And there's an attempt to reach out, but the health plan or the provider, like we just don't have the accurate information for them. What's the thought there? Like, how is that going to work? And I know I just threw out several different scenarios for you, but how would that best work? And then I saw in the report there was a lot in there about CMS investing more in this. So I'm curious if you want to share some of those ideas.
Yeah, so the report is really sort of an implementation plan with measures and other pieces. And one of the things that we thought was important was being able to sort of sketch out a roadmap for this, but not being prescriptive about how it actually happens with those different groups. And so for individuals in terms of, people who decide to either they're more episodic and they may or may not want, say, a continuity. So in the ways that others may want them, we didn't get into sort of that level of detail with the implementation. It's really then sort of back to who are the payers, who are the providers, and then how are those systems of care going to be set up so that we can have some accountability. So the committee didn't really get to that level. It was something that was debated, and again, the cost area around this is really, I think, the area where the rubber meets the road on this. So it's really trying to understand sort of what are the levers that we have, and you've got to bring all the different payers to the table to be able to figure those pieces out. So we have a plan around implementation, but we didn't actually say, here's how you should implement. And so that's what we're hoping some of the other stakeholders around these issues will actually take up that mantle and start to help move that discourse forward.
Great, right. I think we've got a lot of those stakeholders on today.
Yes.
So that's fantastic. So I saw too, and you mentioned it, really just the value of telehealth and virtual health in general, and how, I mean, that could be one of those levers. Just wondering if you wanted to share more about that and how that connects with equity. I know one of the big issues is going to be just audio only.
Yes.
So would love some of your thoughts on virtual health and equity and access, and maybe how that supports this concept of high quality comprehensive primary care.
Yeah, I mean, so one of the things that we thought very strongly was that we wanted to see multiple modalities actually being reimbursed. It's being reimbursed for care, because what we were concerned about is precisely what you just talked about. having populations that may only have access to telephone but not video, not then actually be able to access care. And they may have actually already had relationships with their providers in ways that they don't necessarily need to have that sort of video component. But we want to make sure that there's equal access across all of the different groups. So that was one of the areas that the committee felt very strongly about, in terms of it being important that we not restrict it to a particular modality in terms of telehealth, but that we have all of the options on the table, or the menu, as you would say, to be able to have individuals really be able to utilize the resources that they have access to, and then also that they're able to talk with their providers. So, you know, we particularly within underserved communities, being able to have multiple ways to get to a provider, whether or not it's in person versus telephone versus some other way of doing that, is really important to be able to increase the access and the equity. And then also, as we think about different, you know, populations that are vulnerable, being able to bring in caregivers and others around the table, it's really important to then be able to have telephones and other things where you may not be able to get everybody into the room, but you may need them there in order to be able to help with decision making and other pieces. So being able to have a variety of different modalities to be able to access is really important.
Yeah, no, thank you. That is something that's being heavily debated across the country, including here in New Jersey.
Yes.
All eyes on CMS on that one.
Yes.
So we are ready for the audience Q&A portion, and I already have an important question for you. So in New Jersey, we seem to struggle with primary care buy-in from policymakers who are necessary to get many of these recommendations that we've been talking about today implemented. There seems to be a focus on system-owned practices. So I think hospital systems is what the person's referring to, versus community-based independent practices. Do you have any thoughts on how to, I mean, a lot of what you're talking about is this really community, local, you know, of the community practice. How can we change the New Jersey mindset to support, you know, the models that you're talking about? Any strategies for that? And to make sure that the patients are really seeing the value and, you know, understanding it.
Yeah, I mean, that's the $25,000 question, I think, really. And probably there are many folks on the phone and here in the forum that can answer that better than I can. I can say, as a sociologist and someone who studies how individuals access the healthcare system, and then also how, you know, how we are organized to be able to address it. It's critically important that we actually have our policymakers understanding the experiences of what healthcare is, because one of the things that I think we don't see on a regular basis is, here's what regular people every day are dealing with, here are what our regular teams are dealing with, and really understanding those pieces. So I think it's a question that I don't really have an answer to, because I think we're all struggling with the health system versus the independent, what do you call it, practices. How do we actually sort of work through these issues? And then how do we talk to people? I think what we need to be able to do is to be able to share the stories, share the experiences, so that they see the value in that. And so that's part of what, one of the strategies that we used with this particular report was not just going to the literature, but actually having the voices and the experiences of our advocates and others really sort of at the forefront of being able to bring a personal face to those experiences. So I will leave the sort of the mechanistic pieces to all of my physician friends who are here, because I think that they have a better sense of sort of how the systems will work together. But I think that in addition to those pieces, being able to bring that more human, person-centered, and then also being able to see the value of, okay, there may be even some system-wide practices that are within particular communities, but then are the systems actually working with different organizations and individuals within the communities to best service the folks who are there? I think having some of those discussions in addition to the questions about how payment and the other pieces work out are going to be really key and important to addressing these issues, and particularly for patients who are looking for, what is my experience in primary care? I think often of my mother-in-law, who chooses her doctors not necessarily based on you know, quality rankings, but based on her relationship and how she feels when she's walking in, and the comments that she has about the different settings. And so I think that's going to be really important and key.
No, I agree. I think that's great. I've seen a little bit of that. I know I just saw the YMCA is doing a lot of work around storytelling about the people's life experience during the pandemic, and a couple of our consortia here, maternal consortia, are doing collecting some patient experience data, and I think it is that personal narrative that's really going to make a difference on some of these. But switching back to payment, we do have a question related to payment, but I think it also relates to the physician and nurse and other healthcare provider experience, which you've studied. Is if you could talk a little bit about how financing changes would apply to funding interdisciplinary primary care, team-based primary care. This person's in particular interested in integrated mental health, behavioral health services in the context of primary care. If there's some particularly positive models,
So the report actually does highlight some models of payment that are really, I think, at the forefront of cutting edge on these things. Again, I'm sort of not blanking, but it was not my part of the report. Right. So I was much more focused on the sort of community pieces of this. I will say, though, that we did spend a lot of time talking about the importance of making sure that there is this highly integrated team that is there, and thinking about who are the different members of the team, and then having those members of the team actually reflect. And so thinking about how do we need to now address workforce issues to make sure that we have adequate representation of individuals who are actually sort of have a better beat on the community because they come from the community. So more trying to keep our Jersey, graduates here within the state, or bring them back, and others in terms of the trainees that we have and things like that. So, so I will leave it there for that question.
Are there things that are happening at the medical school or other units of Rutgers that you could share about that? The focus on interdisciplinary training or team-based training in particular?
Yeah, I mean, we definitely have a focus on that. And so Denise Rogers, who's a family physician, and she's actually in our department, is the head of interprofessional education for the Rutgers Biomedical Health Sciences. So our strategic plan, actually, that's one of the areas that we just got done with doing the work at looking at how our programs are set up and thinking about some ways to actually really sort of reinvigorate the work in this area. So I do know that this is a high priority for the leadership at Rutgers. And so education and training has always been a priority, but particularly moving forward, some key areas in terms of interprofessional education, and how do we train and train the workforce in ways that they'll actually be ready to address some of these implementation challenges as we look at moving primary care forward, is really sort of a focus and high on the priority list for the group.
Great. That's good to hear. Um, one of the other areas I wanted to make sure we talked a little bit about was just building that clinician primary care relationship with patients. And I'm wondering if you could speak to that a little bit, really creating that, this is your clinical home, so to speak, within the community, and strategies.
Yeah, so there were a number of strategies, and some of what we were doing was around sort of all of those different pieces are interconnected. And so, for example, even thinking about health informatics, are there ways in which we can make some of these electronic medical record systems more user-friendly in terms of being able to identify populations and then helping clinicians to sort of know who are the folks who are in their panel, how do we get data out about those? There was also, in terms of relationship building, it was thinking about sort of how do we teach our learners about the different populations that they're working with, and within different settings. There was an entire piece around workforce development and how do we actually do the training and the curriculum, and how do we evolve to meet the needs that we currently have. And then there was also discussions around the different pieces of primary care. So we've sort of been through a number of different models, including the patient-centered medical home. And so we've seen a bunch of different quality measures that everyone is actually currently being measured against. And so thinking about now, how do we actually marry the need to be able to address a number of different quality measures with the needs of individuals who may not actually have a population level sort of thinking about their health and what's important to them. So these were all some of the issues that we sort of grappled with in the report, and have some suggestions about sort of places where implementation needs to really sort of look at what are the processes and what are the measures that we're going to be moving forward in the future, because I think that's where we need to really look at sort of making sure that how we're being measured on our performance actually is aligned with the care that we want to provide, as opposed to is just the easiest thing to measure, which is currently the case.
Right. Yeah, that is tricky. If you guys could figure that out, you could actually sell this report.
Yes, exactly. Yes.
So I've got one more question for you. Nobody has bumped me yet. So when you think about primary care in America 10 years from now, and public health or its role in the community, and you're painting a picture, what's your picture? What's your vision?
Yeah, so what I would love to see is more care that is really focused around, less around provision of services and expensive services, and more about the needs of individuals, and thinking through sort of what can we do proactively, then what do we have to deal with reactively, and making sure that we have a system that's set up that actually allows our docs to do what they do best, which is provide care and have relationships, and also our nurses and all of the folks within the practices, without having those extra added distractions of an electronic medical record that is difficult to navigate, and then you have to put resources into that area. So that would be my pie in the sky, is that we can actually do the work that we're here to do and not have to do the other pieces. But that's why implementation plans are really important, because we've got to figure out what are the system supports that we need to have around us. And in our cases, it's some payment reform. I think it's working with our state and our federal entities around how we actually reimburse for the care that we have. And then also there's going to have to be some thinking about how do we redo some of our training, and think about how we redistribute some of the work. So yeah, so as I think about that, it would be really about getting out of the way of the relationships so that those can continue to flourish, and figuring out how to build around them the supports that we need to have in order to do the other pieces.
Well, Professor Hudson, thank you so much for your time and for the work that you've given our country, but for your time today and educating us and sharing your thoughts with us. We greatly appreciate it. And we are going to take this plan and use it as an implementation plan. So you can, you and your colleagues can rest assured that, at least work's going to be done in New Jersey. And I just want to thank you on behalf of our membership, and look forward to working with you and all your colleagues at Rutgers as we move this forward. So thank you for being here today with us.
Thank you, Linda.
And at this time, I'm going to turn it over now to my colleague, Kate Shamzad, who's the director of our Medicaid Policy Center. And there she is. And Kate is going to moderate the second part of our conference today with our panelists. So Kate, you're up. You ready?
I'm ready. Thank you so much.
Okay.
I'd like to say that I'll be leading a fireside chat, but unfortunately I'm here next to a fireplace that doesn't work. So you can just envision that. But I'm so grateful to be here today with everyone. I know we're going to get all of our panelists up here and settled. I'll introduce myself while we're waiting. Like Linda said, I'm Kate Shamzad, the director of the Medicaid Policy Center at the Quality Institute. And I have the privilege of being your moderator for this afternoon. And I'm seeing all of our panelists pop up. Oh, there we go. All right. So thank you all for joining us for this esteemed panel. It's my pleasure to introduce this group of individuals. In no particular order, I'll start with Dr. Mary Campagnola. She is a family physician and geriatrician, also serves as the medical director for value-based care and payer contracts as part of the Virtua Medical Group. She's a member and lifetime fellow of the Medical Society of New Jersey, where she was president from 2012 to 2013. Additionally, Dr. Campagnola was past president of the New Jersey Academy of Family Physicians and director for the board of the American Academy of Family Physicians and AAFP Foundation. She also serves on the board of directors for the Quality Institute. So welcome. Next, we have Dr. Ramos. Dr. Ramos is a family physician activist with a decade of experience practicing full-scope family medicine with obstetrics in both rural and urban settings. She is the medical director for Gatehouse Treatment Center and regional medical director for Aledade. Locally, she's president-elect of the New Hampshire Academy of Family Physicians and a member of the New Hampshire Medical Society Council. Welcome to you. Dr. Elizabeth Spector joins us and has taught as a faculty and assistant director at Somerset Family Residency Program for over 16 years. She was elected by her New Jersey family medicine peers to serve as a trustee on the New Jersey Academy of Family Physicians Board of Trustees and was appointed by Governor Corzine to the Emergency Medical Services for Children Advisory Council of New Jersey. Dr. Spector was delighted to join the Somerset County Partnership Health Center team in fall of 2017 as the medical director. Welcome. Next, we have Dr. Kumar Dharmarajan. He's a cardiologist, geriatrician, and associate chief medical officer at Clover Health, where he leads its clinical programs and R&D initiatives for its most medically complex members. He also serves as chief clinician and governing body chair of the Clover Health Partners direct contracting entity. His work has appeared in top medical journals, including the New England Journal of Medicine, JAMA, and Health Affairs. Thanks for joining us. And last but not least, we have Carolyn Hoytella. Carolyn is the Vice President of Practice Resources with Conventus Interinsurance Exchange. She has more than 23 years of expertise with the clinical and business optimization of physician practices by helping them apply data and workflow processes to support practice transformation. Welcome. So you can see why I introduced this group as an esteemed panel, given all that I've just listed. We're so glad to have you today to join us. And we're going to start with a few introductory questions that I'll open up to all of you. First, as a bit of background, could you all share a little bit more about yourself and how you first started working within healthcare? Happy to have you volunteer and take yourself off mute, or I can call you in no particular order. Go ahead, Dr. Campagnola.
Hello, everybody. So I've had a long and very satisfying career in family medicine in New Jersey. I initially started, though, back in grade school when I always wanted to be a doctor, but I thought I was going to be a neurosurgeon. And, as I got into medical school, I realized I had more of a holistic view and I wanted to take care of people at all ages. And similar to what was spoken about in Linda's interview with Dr. Hudson, I joined to get a scholarship. I joined the National Health Service Corps and had the opportunity as a recipient of the scholarship to do a preceptorship in family medicine in New York City and East Harlem back in my student days. And that basically clinched my decision to become a family doctor. And so then I did carry out my residency in New Jersey and then went to my Eastern Shore of Maryland to do my service commitment for National Health Service Corps. And then I returned to New Jersey after that. I've had a practice career of 21 plus years in the private practice in New Jersey. And then in 2008, part of our group, which had been 10 doctors in 3 locations, we started the first beginnings of the Virtua Medical Group. And since then has grown to more than 1,000 clinicians. In that role there at Virtua Medical Group, I continued my same practice basically, but also have been serving as the primary care medical director initially, and then also had some opportunity to work in graduate medical education, where we did have some examples of interdisciplinary GME, so we could talk about that a little bit later. And then also after that, just the past couple of years have served in this value-based care role. And that was really why I started with the group in the beginning, was to get some assistance with becoming a patient-centered medical home, as well as implementing electronic records. And that really did set the groundwork for some of our value-based programs now. And so I'm sure we'll talk more about that as the questions go on. So I'll stop there. Thanks.
Guess I'll introduce myself. Elizabeth Spector. I am a New Jersey born and bred. Grew up in Somerset, right next to New Brunswick. So of course I went to Rutgers. And while I was an undergrad, I started out pre-med, and I actually hated the people in my classes. It was so cutthroat. I said, I don't think I would need to be a doctor. And so I was a philosophy major, loved it. And then what do you do with a philosophy major? There's not really a career in philosophy. But I did say to people that I was going to find a mountain, sit on top, and give out worldly advice, which of course meant that I had to go into the Peace Corps in Nepal, which I did for 2 years. So I was actually in the Himalaya and teaching science. And while I was there, I said, you know what? I can't let people that I don't like in my classes be the reason that I don't pursue what really felt like a vocation to me. So when I came back to the States, I then had to take classes to get into medical school, went to RWJ in New Brunswick, and then did my residency at Hunterdon. And then after 1 year of just working in a small office, I joined the Somerset Family Practice Residency as a faculty and assistant director. And I remained there for 16 years, loved doing the full spectrum other than OB, seeing newborns to old age, but decided that it was time to do something a little bit different. And the opportunity came about to join the Somerset County Partnership Health Center, which is in Somerville, so right down the road from where I'd been for the last 16 years. This is a new model that I will be talking about later, but this job as medical director here has been really a wonderful blend of both the family medicine background that I have, along with the master's in public health that I attained during medical school.
I'll jump
I'm
in.
happy to go next. Oh, go ahead, Carolyn.
Do you want to? Okay, thank you. Well, I'm a very different track than everybody else. Dr. Campagnolo, I've known you for years through the start of my career, which really started when I was at New Jersey Hospital Association, working when they had a library there. And actually, I went to Rutgers to get my master's in library science. And for me, I think the challenge at Rutgers was I was really focused on the clinical and the sciences side. And that's not what, even though it's library science, they had seen a lot of. So my balance was really working in the library science world and helping most of the hospital libraries establish their systems and doing research. And that's where my love came. And I started to work for what was once known as the peer review organizations or the quality improvement organizations, and the QUINs, as they've transferred their names over time. But that's where really I started my career of loving data and working with quality measures and practices in hospitals, really getting exposure to what data can do, and how it can be used, and the power of really implementing change and working with practices through change. A lot of my work started with PQRS, which we thought was hard back then, to Docket, which is the Doctor's Office Quality Information Technology Project, the precursor to what we know as MIPS and the regional extension centers. So I've had a lot of years of really working in the ground with practices, really helping to implement change. And moving now to Conventus, I get to bring that to a whole different area, and that is also partnering that with risk management and the changes that we need to see there and the risks that come with all of these changes.
Hi, everyone. Kumar Dharmarajan. So in terms of how I got here, so my father's a geriatrician, my mother's a cardiologist. I'm a geriatric cardiologist, trained in both, so I didn't fall very far from the tree. I think both my parents were very happy in their professional careers, and so that rubbed off on me. I've always wanted to take it slightly different. My father is more of, I would say, an academic and administrator, and my mother is a clinician. They both worked in, I would say, challenging settings where patients experience a lot of social inequity. So my mother's worked at a hospital, New York Health and Hospital Corporation Hospital called Lincoln Hospital in the South Bronx for 40 years as a clinician. And they're still working. My mom is 70 full-time, my dad is 77. They still work full-time. It's what they love. And my father's also worked in the Bronx as a clinician in the Montefiore Health System for, again, almost 40 years. And, for me, I always wanted to have a slightly different angle at it. So I knew I was really interested in science and medicine, but I also wanted to take a more systems approach to it. And so, I majored in health policy type courses, and I went to business school. And for me, then after lots of years of training through internal medicine, geriatrics, and cardiology, I really took an academic part to start, where I was doing health services research that was policy oriented, quality oriented in the Medicare space. I built quality measures for Medicare that Medicare uses in many of its reporting programs, and I came to Clover Health, where I am now in 2017. So I've been here almost 4.5 years because of the promise that technology had, and I think still has, in terms of helping improve care, helping improve the lives of physicians and other providers. I think a lot of our technology is patient facing, and that's great. But at the end of the day, it's clinicians who deliver care. And EHRs are terrible. They're revenue cycle tools. They're not clinical tools at the end of the day. And trying to create technological and scalable ways to improve the lives of older adults. And felt that trying to do that from the payer perspective, which is where I sit now, is a really good place to do it, because payers have, other networks and leverage that just like a technology company wouldn't have. Happy to be here.
Well, hello, everyone. Thank you for the invitation with this esteemed panel. My name is Marie Ramos. I am a family physician, and a little bit of my story. I am a first-generation American from my family, and my concept of what health and wellness is and always has been was always community-based. Just part of our culture, that understanding that we are interconnected and interrelated with one another. And I had a strong interest in impacting what I felt was the most foundational unit of community, which is family, however we define it. So at the age of 12, I was very clear. I'm either going to be a teacher or a doctor. Those were the two most influential people of my life. So clearly, I decided to go into the medicine route, understanding that I like to teach people. I like to teach people who want to learn. Interestingly enough, as a family physician, I spend all of my time teaching, coaching, inspiring, and invigorating life and agency within the practices that I've been in. I've had the pleasure of also being a National Health Service Corps scholar as a result. And being a first physician in my family, I was very relieved knowing what I wanted to do, that I didn't have to come up with a whole new specialty all by myself. Entering into medical school, I realized, oh, there's something that does it all, that touches the family unit, and that also looks at the family unit within the context that they live, and that is family medicine. So from the onset, have had a passion for upholding what we now call health equity, but really creating an environment that is most ripe for people to have the best opportunity to be the best form of themselves. And I'm glad to be a part of a fraternity of healthcare pioneers, I'd like to call ourselves, in really trying to push the envelope and move the needle towards a place where patients have their a choice to be the best form of themselves. I've practiced as a result of my National Health Service Corps time as medical director in the mountains of California, being one of 3 family doctors, delivering babies, doing hospital medicine, running a rural health practice, and helping at the onset with value-based care for pediatrics in our community. And also alongside my journey working in organized medicine as a former board of director member for the AAFP as well. More recently, though, I delivered my last baby summer of last year, 1000th baby. And because of COVID, seeing the immense pain and struggle that my colleagues and my healthcare professional colleagues were going through, I decided to take a step back from full-time clinical practice so that I could help reinvigorate, re-inspire, and use my skill sets to help bring in a pipeline of new healthcare frontline people and to inspire, again, joy in practice. So I still see patients as a Gatehouse, as medical director at Gatehouse Treatment Center, still an under-resourced population, those who suffer from substance use disorder. But I have the esteemed pleasure of getting the opportunity to meet and work side by side with many independent primary care practices right here in New Jersey for the last year, hearing their stories, amplifying their innovation and wisdom within the industry here in New Jersey, and most importantly, finding ways that we can support through Aledade, support our practices to reinvigorate their joy in practice and to create legacy once again within the communities that they serve. So I'll be speaking and touching on various experiences regarding that, and how maybe we can inspire more innovation to bring back, as we heard, the value of primary care in our structure here in New Jersey. Thank you for the invitation.
Thank you all so much. It's fascinating to hear how your journeys have brought you to where you are today, as well as the many different places that they've led you around the world. So I heard mountains and a couple of stories and a number of different locations in the New York metropolitan region listed. But all of that takes us to today's conversation, which really is focused on how your background and commitment to primary care as a public good has gotten you into your current role in the programs that your organizations are leading. And so I'll walk through a number of different questions with you, really highlighting the work that each of you is doing that's innovative in this space. First, Dr. Campagnolo, I'd love to turn to you as a geriatrician. Can you tell us a little bit more about how important it is for older adults to have that trusted relationship with their physician, and a little bit more about why that's so important?
So I think that, again, as we've said, the trusted relationship for all patients is really important to have a usual site of care. But as we age, we have more complexity in our lives sometimes as far as the natural aging processes of our bodies. And so as family doctors, we're really trying to keep everybody at the optimal level of the health that they could achieve. But again, there's so many issues that come into play. And so what we try to do is, again, there's no other specialty, I think, that kind of asks the patients, how many times have you fallen this year? How is your vision? How is your hearing? Who do you rely on to help you? How do you get transportation? So those are all the issues I think that family physicians are adept at addressing and trying to help guide a patient to be the safest in their own environment and to maintain their independence. And so, I think the other issue with senior citizens is polypharmacy, where many different specialties are sometimes prescribing medicines for them. And we can kind of act as a kind of an overseer of medicines to kind of help to be sure that they're taking the most appropriate medicines for them, avoid interactions, avoid significant side effects, which sometimes happen and lead to medical disasters or hospitalizations. So I think for many reasons, it's really important to have a family doctor at any age, but especially as we're aging, that it's really a great source of help to navigate the health system and for caregivers to help them in taking care of their loved ones. So there's many aspects of our day that are involved with dealing with family members as well as the patient themselves. We also do house calls. We also do nursing home. Again, over the course of my career, I've certainly always included those in my practice. Currently also work on the New Jersey Nursing Home Administrators Licensing Board. So I've kind of seen all of the aspects of care in the homes and what, the COVID has also brought about as a result. So, but I'm very, very happy to care for seniors and all of their family. And the other issue that I think is important is that we can also often see husband and wife teams together, daughter and mother teams. And so we can kind of address, make it most efficient for the families to come and visit us. And also, again, telehealth is another aspect I'm sure we'll talk more about, but that's been something we've really been engaging with to help patients who can't transport easily and, again, still need to connect with us.
Thank you so much. It's such an integral part of the care that these individuals are getting as they age, the primary care provider. And it sounds like in your work and the work of others, you've really been nimble and creative to be able to get that care to them however they need it best, which really serves to build that trusting relationship. So thank you. Thinking about, these primary care providers, and I know Dr. Ramos, you really talked about how in the last year you've transitioned to be able to support primary care more broadly instead of just being in full-time practice. I'd love for you to tell us a little bit more about the work that Aledade's doing with primary care practices, particularly related to how you've had success in value-based arrangements.
Definitely. One of the things that drew me to working alongside Aledade is its commitment to providing a milieu for maintained independence for our small and moderate-sized practices, independent practices. And at the end of the day, wellness really it's a full circle effect, Kate. At the end of the day, people want to be seen. People want to be known individually. They want to be more than a number. And I would venture to say that even my colleagues in the healthcare system want to be more than just a number. They want to be more than just a cog in the wheel. And it was, for the most of us, not part of our plan to be expert at putting in numbers and necessarily coding or experts, right? That wasn't necessarily what I thought of in writing my medical school essay going in. And so coming into Aledade, really, we are at a crux. What COVID has shown us is that if we are not taking responsibility of the communities that we serve, and we are not only just seeing the patients that have the opportunity to come into our office, but if we don't have a higher vantage point to look at the community and the populations that we serve, then we're going to have a losing battle. And the frustration that a lot of my colleagues feel is that that weight is put on our shoulders. It's either coming from external forces telling us, our payers included, telling us what quality metrics we need to meet and how we're going to communicate them, or the fact that we are just bursting at the seams and we just don't have enough space for the people that are asking to be seen, the people that we care about. And so one thing that Aledade does is it helps to create a lift for our practices. We are able to take information and insights from the communities that they serve, and we're able to put that information in a way that is translatable, both to payers, but also actionable for our partner practices. I have been griping about this as well on the community health center side. One of the interesting parts with community health centers is that although we have this ingrained concept of integrated multidisciplinary care, by and large, community health centers are still very much incentivized to work on a fee-for-service per click basis. And so there is an innate malalignment of values, particularly with those that come into the setting who are mission driven, but yet are working in an inefficient model that prohibits us to expand on our margin. And one of the most exciting parts in working with Aledade is I not only get to work with our independent private practices, but I also get to help our community health centers as well to be able to maximize and really speaking to the values that the people within those centers have, meeting the mission to the margin. The other thing that I think that really, I think, drew me to working alongside in this particular way is being able to explain the why behind the business of medicine. And unfortunately, or fortunately, that we have so much information now available to us that we can help our clinicians really take autonomy and elevate their agency to make informed decisions about their practices, making the decisions that are right for them, right for the patients, and right for the community. And what that does at the end of the day is that is an antidote to burnout. That's an antidote to the moral injury that we have all been experiencing and we can't unsee anymore. So it's really threefold there. It's taking care of a workforce issue, it's taking care of our patients, and it just makes good sense for the fiduciary responsibility that we have for the healthcare system and making it better.
Thanks so much. It sounds like you're really doing your part to reduce that burden on the individual provider and the practices that they're in to make the system better. So thank you for that commitment. Dr. Spector, I'll turn to you, and I'd love to hear more about how the Integrity Health model works, particularly related to driving better outcomes for your patients.
So I joined the Partnership Health Center here in Somerville in 2017, but actually the original two sites are based in Long Branch and Toms River. The model is one that takes, so this doesn't function in a bigger sense in the community, but it is directed specifically towards public community sort of workforce. So the first two are based out of school districts, and mine is based out of Somerset County, the Somerset County workers. So we are a standalone health center with a very robust set of services that provides electively care for the people who work for this entity. So for Somerset County, it includes people who work for the library system, the sheriff's office, parks and recreation, recycling, a variety of different entities. And if you work for any one of these entities, or you have a eligible member of the family, you can come to our health center and have the services that we provide. The services that we provide include, obviously, I'm the physician there. We have physician extenders, so we've got nurse practitioners here as well. We have physical therapy on site. We've got x-ray. We have a billing specialist. We have a care coordinator. We have a LCSW for behavioral health, and we have a pharmacy. The key thing about our model is that it is not compulsory. So you don't have to come to our office. You have, as an employee of Somerset County, you have Aetna insurance. So you can go to the primary care doctor you've been seeing forever. You can go to specialists. But if you come to our office, everything you get is free. There's no copay. You don't pay a thing. So initially, a lot of the county employees sort of looked at us and said, you know, that sounds nice. There's a catch, I'm sure. And they weren't coming for anything other than maybe, you know, I started to feel unwell today. And by the way, we're situated in the hub of where many of the offices are. So people would maybe walk over during their lunch break and say, I don't feel so good today. And we would take care of them. But what we started to find is that they kind of liked, number one, just the ease of access. You know, they could call and say, I want to be seen. They were going to be seen the same day. Number two, a lot of times people would come in for something fairly acute, and we would say, you know, this boil you have is kind of big. Let's get some blood work and make sure there's nothing else going on. Well, I have one example. Early on, we saw this guy who just simply didn't go to see the doctor because, you know, I'm okay. Young guy in his 30s. He had a big boil. So we said, let's get some blood work. He's a diabetic. Didn't know it, wasn't going to see a doctor, wasn't going to do anything about it. But now we had two problems. We had a boil that needed to be, number one, opened up and packed, and then he had to come back repeatedly. So no copay. So he couldn't say, you know what, I can't afford to pay $15, $20 every other day for a month, which this was a big boil. It required a whole lot of intensive cleaning and work. Number two, I can't afford the antibiotics. Got you covered there. You got your free antibiotics. Number three, diabetes. I don't know how to check my sugars. I don't know what to do. I have a nurse who can actually show you, can do diabetes education as far as diet goes. And I have a care coordinator. Did I forget? No, I think I did mention the care coordinator. So this is somebody who's coordinating any care that might be needed outside of our office. So now we've got all of these services that the patient has paid nothing for. Oh, and the office is close to where he works, so he doesn't have to drive a half hour or rush there. We're open from 8 a.m. until 6 p.m. and Saturdays and Sundays from 8 a.m. until 1 p.m. So there's no excuse you can give us for not showing up and getting the medical care that you need. His A1C is now like 6.3. He has the education, he has the access to the medication, and he no longer has infections that we need to deal with that are secondary to the primary problem. So all of these robust services have really been showing the return on investment that the county has paid forward to provide this care. And the patients' word of mouth and just good experience are coming more and more. We never closed during the pandemic. We offer the virtual visits when it's appropriate. We have people come in when it's appropriate. But you know, there's never been a time where people weren't coming in. We've also, because of COVID, had to be nimble. We have the ability to test for COVID as of a year ago. So we were triaging patients. Can you come in and be seen? Let's check you. We've got a PCR system that we get the results back immediately. Well, within 40 minutes, I should say. And then we can decide whether it's appropriate for them to be physically seen or whether they're going to be seen virtually. In partnership with the county, So the county has the Department of Health. We have been working with them when there have been various needs that have come out of the broader community. So for instance, we were enlisted to hire nurses to help them with the Somerset County COVID testing. So we had what we called our SWAT team that would go out to the various sites that they had to do the testing. And now we are embedded within our office. We are doing the COVID vaccinations as well. In addition to that, we have worked with the county administration to help with the wellness committee that works with the county employees. And this is a multi-tiered sort of approach of workplace interventions for wellness. So it's a many levels of working within the community of the employees, but also broader to include employees that don't necessarily use the county insurance to afford, wellness as well as medical care. So that's a little bit about what we do.
Sounds like a tremendous model to promote, both overall health, but drive people into, better wellness for their life, for longevity. So thank you for sharing that and for the example of the young man you talked about.
Absolutely.
Shifting to you, Dr. Dharmarajan, could you tell us a little bit about how Clover Health has used contracting and strategies to promote primary care?
Sure. And maybe I might even take it a step back, right? So I would say maybe payer strategies to promote primary care. So, Clover, based on where we operate, there are areas where payers generally don't like to go because they're considered quote unquote poor payer mix areas. So we have a lot more members with social health determinant challenges. We're more than 50% people of color, which is unusual for Medicare Advantage plan. The percentage of our members who are eligible for Medicaid and Medicare is significantly higher than the average Medicare Advantage plan. And so we've had to do a number of things to promote primary care in that setting, right? So for many of those folks, cost might be an issue, right, in terms of accessing care, or they're in communities where there's not a huge number of health providers there, right? Just we've talked, everyone's heard of food deserts and things like that. Same thing in areas of higher poverty, there's a lower density of providers generally, right, clinicians. And so one thing is we've eliminated that sense of in-network, out-of-network. Linda was mentioning in the earlier segment, this concept of assigning a PCP, HMOs, narrow network. We actually think, narrow networks in settings of higher health risk, that's not a good thing, right? When, patients may not be able to use their local provider, or they might have to travel farther, or face higher copays for using their local provider, like that out network thing. So we're a PPO, right? So that means we generally believe in, just like traditional Medicare, right? There's not this concept of highly managed networks in and out. We believe that's just really important in situations of risk, right? Because if you curtail access further for folks with health challenges and in challenging environments, we don't think good things will happen. The second thing is that in challenging environments, right, a bigger percentage of patients have Medicaid or Medicare, which tends to pay lower than commercial health insurance, right? This type of health insurance that, we get through our jobs, as an example. And so what do providers in those challenging settings have to do to make ends meet if they're getting paid less per visit? They got to see more patients, right? It's a math equation at the end of the day. And if providers have to see tons of patients in a day, it's harder to deliver really excellent primary care when you have to, unfortunately, churn through patients. You can't, Mary was talking about addressing patients holistically. That becomes harder and harder the less time you have with a patient. And so you're not going to ask about, the falls or the hearing, but the hearing can be incredibly important for an older adult, right? And the vision and, things that are, may not be, where most physicians are. 5 minutes, this is what I'm going to talk about with the patient, right? So what we do is, in those settings where providers face more challenges from a payer perspective, is we actually pay a $200 flat fee for a primary care visit, right? That is a lot more than an average primary care provider is paid for a visit. but there is a little bit of something we expect in return, right? Which is Clover. We index on having a technology platform. Aledade, as Marie Elizabeth was saying, also has their own technology as an example, right? But we believe that in that platform we can surface key information that, in return for $200, we provide information that doctor may or may not know, right, about a patient. Their recent hospital stays, as an example, they had an ER visit with a given diagnosis. This is, at least as far as we know, our best data on quality gaps that Medicare cares about, and NCQA, as HEDIS, and there are these quality measure areas, right? Or opportunities to do care management. We might identify social health risks, right, and opportunities to address that, right, which are maybe not traditional medicine in some people's perspective, but super important to patients and their health outcomes. So that's our strategy, right? So we try not to narrow the networks. We try to keep them wide. We try and, most of our primary care visits involve this higher payment. And we really believe in a health system. I think, it was initially shown the percentage of costs that go to primary care. I think it was 3% on that slide. In a world where 4% or 5% of costs could go to primary care, we think it's probably a much better world for patients. And it'll sort of give primary care providers the time to actually develop relationships, really investigate issues in a more holistic way, because we really do believe that PCP, we do view that person as really the captain of the ship. All providers are important, but I think the place where our health system does need greater investment is on the primary care side. So those are a few things we do that relate to that investment.
Thank you. To borrow your analogy, it sounds like you were really trying to steer that ship back toward preventative care, whereas it's been channeling along toward the emergency room for many years. And if we're able to put that focus on really high quality primary care, even with 1 or 2% extra investment, it really is going to make all the difference. So thank you for sharing that model from Clover Health. Carolyn, last but not least, over to you. I'd love for you to tell us a little bit more how you work within your organization with practices to help mitigate risk as they participate in some of these different value-based arrangements. What does that look like on the quality of care that your patients are receiving?
Thanks, Kate. Part of Conventus, so we're not your typical professional liability or malpractice insurer. So we don't have the traditional risk management department either. What we did was we realized, about 5 years ago when I came in, was that payment models were definitely changing. And Conventus had to partner with we call our member insureds, to really help navigate the changes that they were seeing and to help them also manage risk. So what we do is we really work across multiple practice areas to look objectively and holistically at how and what changes are being implemented and how those changes could implement and could sort of be challenges for staff engagement, patient satisfaction, patient safety, and quality of care. There's always risk. There's always ability to have gaps that are being created by what could be perceived as variations in care because of the mix of measures and what's going on at a practice and who is being impaneled here and what do we do. So what Conventus does, and we've talked to some of our members, we realize that there's a lot of risk where practices don't fully understand the models that they're in and the impact they have on their patients. Their staff is not completely engaged. They don't know how their roles are being changed, expectations. They don't also have a clear defined way of working and protocols and processes. We find that those keep changing, but there is some consistency. There's siloed, sometimes staff. We also know that patients aren't always informed of what's going on and the changes being made based on models that are being adopted or just the natural change in healthcare. I find patient education and really patient engagement still is an area that has so much room to grow. And then we look at quality measures. We look at documentation. So at Conventus, we actually have a practice consultative model that's a very open approach. And what we do is we really assess all areas of a practice to see what are the gaps, where can we help them really move along that continuum. So we help with facilitating training for teams, helping provide clear roles, responsibilities, protocols, plans of action. So while everything else is moving around, we're really helping to make sure they understand who is a part of the team and what that role is. Accountability, we look at that. Again, these are things that open risk. We also look at what the non-physician providers are doing and how are those, whether it's a delegation agreement or collaborative agreement, are those in place and do they meet regulation? Again, areas that when we start to grow and change and adopt new models, how are we working? To something that Dr. Campagnolo said and Dr. Dharmajan said, that we also look at the documentation. Is it being collected consistently? Is something being missed due to a time constraint that maybe is not considered as important, but it really is? That fall screening, that depression screening, what are you doing with that information and how are you managing it over time? And for us, we look at gaps in information and missing information, or information that is pulled from an outside source, since a lot of EMRs, as we know, are not truly built well enough for documentation. So in the value-based world, practices use outside data aggregator, information sources, but they're not necessarily connected together. And that leaves a gap of information in an EHR world. And from a medical malpractice standpoint, that's where we look at risk. So we start to look at what are you doing in one system for one payer that maybe you're not doing in another for other patients that should be managed just as well, but maybe they don't meet that chronic care scale. And how do we do all of that across the board to really manage variations so we're not seeing them and that we are keeping control of that? We also look again back at just third-party vendors and engaging in third-party processes, whether it's remote patient monitoring, chronic care management, transitional care management. There's a players coming into healthcare because of value-based, but because of other opportunities. And we want to look at that, and we do, to really help say, are you missing something? Is there more that you can do? Is the care consistent? And is the care acceptable for all of your populations beyond just the impaneled ones because of one piece or not of the system, but are you consistent across all the payers and all patients?
Thank you for helping us understand that model better. It seems like in addition to doing all of the work that you generally do, you're really focused on positively enforcing your providers' practices and seeing where those risks are, but then also coming up with solutions. So thank you for sharing that with us. I'll take a minute and invite our participants to send in their questions. We've reached the participant Q&A portion of the event. So please drop those into the chat box and I'll be monitoring that. And as we wait for those to come in, I know we've covered past and present with you all on the panel today, but since it is that turning point of the year where we think about the future and setting those goals for the future, I'd love to ask you, what do you think that primary care will look like in 10 years in both the US or in New Jersey? What is your hope for what it might be? Anyone's welcome to jump in.
Kate, I'll start. So, I think that we're at a flexion point, like I said, in really healthcare history. This recent pandemic has jolted and required a shift in our approach to public health. And I think for the first time in a long time, public health has become very personal. And what we're seeing is that and I think primary care is going to be more, I think, broadened as far as defining what is a medical home? Will we be discussing a medical home, or will we be discussing a medical matrix, right? Understanding that our patients, 80% of their healthcare outcomes are outside of my office. And so we need to understand what are the intersectionalities between those social determinants of health, and then also incentivize those evidence-based mediating factors that we know cause downstream cost savings. The second thing I think that we're going to recognize, and we're going to start shifting, is creating a value-based 3.0, 4.0. Right now, we are in this push and pull between our payers and our clinical entities for data. And really what we need to do, instead of working retroactively on information that is from quarters ago on how we're going to shift now, we need more real-time insights and data metrics so that we can make justifiable and evidence-based decisions about the populations that we serve. And so how can we evolve our current structures and models in order to get more readily information and provide more regional benchmarking, so that we can understand where we've been as a region, and that can help to create a directionality on goals, quality measures regionally, and then also tendencies and trends that we can help to be proactive about and preventing. The last aspect that I think will evolve naturally through this interface with primary care is really engaging patients' autonomy and agency within the healthcare system. Right now, our patients are very much riding with the waves. They're moving along with the trends and with the incentives that are being put around them, but there tends to be a lack of engagement for lots of different reasons. And so how can we reduce and minimize barriers and bring healthcare to the patient as opposed to the patient coming to healthcare? We're doing that already. We've seen the glimmers of that with telehealth parity, extending that even further and creating extensions into the patient's home. Remote patient monitoring is another opportunity where we can actively co-manage and co-facilitate the patient's opportunity and get real life real-time information and data so that they can have behavior modification. And then lastly, helping the patient understand that this complex structure can incentivize them as well. And so where is the incentive for the patients for their behavior modification? So where is that positive incentive? And I said lastly, but really the last thing I think is bringing more recognition to our new primary care clinicians coming into this milieu that we're evolving from. And so how do we improve payment models to make primary care and the focus of preventive care more of a reality for our primary care clinicians? How do we not only improve baseline contributions and reimbursements, but also how do we remove the administrivia that's involved with everyday primary care practice to bring back that joy? And so it's those four quadrants really is, again, good for the patients, it's good for our practices, good for society.
I just wanted to pick up on where Maria Elizabeth started there, which again, I totally support all of the items she said. I think I've been practicing long enough now that I've seen the 1996 IOM report. I've seen another one in 2002, Crossing the Quality Chasm report, and then something in 2012, all being very hopeful for primary care in the future. And we really haven't seen the promise of all of the things in those reports. So one thing I would hope for in 10 years that will say we really did implement high quality primary care after trying a lot of things over the years. So that would be my first thing. I think, as Marie was alluding to, I think we need to look at our workforce, the diversity of the workforce to reflect the populations we're serving around the country. especially in New Jersey, and also make it a value proposition for a student to choose to be in primary care and to spend their career in this field. And so that would involve, I think, ultimately looking at probably up to 50% of medical schools, medical students choosing to become primary care physicians and continuing to practice in primary care. Again, making the value of their career and making them able to pay back their debts in order to maintain the career. I also think we should be having a view in New Jersey where every patient would have a usual source of primary care in a medical home model with a team of people that would take care of them, and that they value that team, and that the payers would value us. I think I appreciate what Dr. Demarjian was saying about 1 or 2%. I really feel it needs to be much higher than that. And I'm glad the New Jersey Healthcare Quality Institute has helped put some of that language in the budget for us to start studying what number is right. But I think, again, we need to be looking at a model where primary care is one of the most invested parts of the health system. And I think we'll see other returns on the other end on that in outcomes that will show better health and lower cost over the years. So lastly, I think also Marie touched on this, is just how do we have a data system that would be more seamless, more efficient, and shared among every part of the health system, not using multiple data platforms that don't always talk to each other and take too long for the end users to input data. So those are some of my wishes. Again, I think lastly would be GME in general. I think we also need to look at how do we delink graduate medical education from totally hospital-based support. And so we really need to look at the whole CMS model, which is still frozen in 1997. The caps on education in the first place, but also linking to the hospital where we're focusing more on sick care rather than well care. And so there's other models out there that I think have not been tried in New Jersey, in the teaching health center model that has been used more for rural areas, but really could be used anywhere as a way to kind of train people where they're going to be working in the kinds of work they're going to be doing. They need some grounding in some of the hospital work, but I think ultimately that doesn't help to develop primary care physicians.
I can say that I really appreciate all the insights of the other panelists. I see that where I am is a little bubble in a much bigger society. And, my hope in 10 years would be that models like this could be brought into a larger community, because I see the benefits on a very micro way. The patients are being well taken care of and they are engaged. They're coming back and they enjoy being a part of a medical home that provides them with a medical matrix as well. So I appreciate the thoughts that are being addressed. I hope that in 10 years, there's more engagement now that we have seen that the public health departments are so crucial, that there's more engagement between the medical offices and the community outreach that's being done with the public health departments, because I think that they're crucial. And I think we all saw how poorly we were equipped to deal with the pandemic initially. Once we got the COVID vaccine, how difficult was it for people to actually register initially? And why, in a world where we have all of this, information technology, could this not have been done more quickly and seamlessly? And instead, we had people saying, I've tried for days now to get on the website and I can't. And I tried to do it for my parents, my 95-year-old dad. He's like, can you help me? I'm like, I'm trying, So I hope in 10 years that we have, the ability to more nimbly have public health interface with the primary care setting.
So folks on this call have said a ton of different things. So I'm just going to try and maybe index on a few points. Everything makes sense, really. So I think one is 10 years from now, and we'll see where this goes. So primary care providers around the country are much more likely to quote unquote take on financial risk than they are in New Jersey. And so, for me, I think that's something that needs to happen in order to provide primary care providers with the time and space to be able to actually invest in their patients. Because most payers actually know that investing in patients takes time, and the current model doesn't make sense. And it's actually, unfortunately, physicians and AMA and the RUC and some of these committees that determine the relative value of services, right? So it's within the field where the relative value of services is being defined, unfortunately, right? If you consider the field medicine broadly. And so in New Jersey, it's a place where we're going to have to go, but it's been challenging to date, right? And obviously Aledade and others are helping move practices in that direction. A little story. So my mother-in-law is a physician who works at a practice in Texas that's value-based. It's mostly Medicare and Medicare Advantage. She's able to see 13, she's a primary care provider, right? In a rural setting. And she's actually able to see 13 or 14 patients in a day, right? And give each patient 30 to 45 minutes for that encounter. And it's supported, right? And it's generating value, right? And it's because her practice, ultimately takes on financial risk, right? And has an arrangement with health plans there. But I do think, and I'm really indexing here, it's not that I don't think all the other stuff folks are saying is important, but, and I see this from the payer side too, right? So I see this, right? And I realize change is hard, but there is a tension in New Jersey, right? Between more traditional, and in other places too, right? Payment models, which I don't think do service to good primary care, and they don't do service to primary care providers, because it's really the treadmill going on and off, seeing 20, 25, 30, maybe more patients in a day. And it's going to be hard to move from that if we don't have a different financial construct. And then everybody has to agree to it. And there needs to be things that help unlock it. Maria Elizabeth was talking about data. Data is critical, right? But that's where we're going, right? If we look at all the federal policy around patient data, more and more is getting unlocked, right, every year, and it's supposed to be shared, right, with patients. And so I think there's an opportunity to combine different financial constructs with data and give a little back more time to primary care providers, but then primary care providers also have to agree to participate in these equations and being measured in certain ways that may not always be comfortable, right? But it's going to be hard for a payer to say, well, you can see half the patients. Let's say you're seeing 25 in a day, and now you're down to 12, right? Or 13 or something like that. But there's going to have to be something back in return that's quantifiable, right? But I think that's great opportunity, right? Now that doesn't solve supply of primary care providers. So if every PCP is seeing half the patients in a day, so who's going to be delivering primary care, right? That's another question that needs to be answered. And it's an opportunity, I think, for PCPs. They already embrace the patient more holistically than many other, maybe all other specialists, right? Specialties within medicine. And the payer world understands that holistic view of the patient, the social health determinants, et cetera, matter. They can matter more for bottom line cost than like someone's hemoglobin A1C, right? So if there's a world where there could be greater financial risk and a way for PCPs and primary care to take even greater accountability, it might be scary, right? In tandem with health plans for these social health factors, because if PCPs aren't doing it, no other specialists or subspecialists in medicine are going to, right? How do we create that environment together where the patient is well served in the end. They get more time, they get viewed more holistically. The provider ends up having more time to do that and address. Most PCPs go into, or many go into primary care because of that calling, that desire to build relationships with patients. But I think there's going to be, like any times there's change, there's going to be challenges and tensions on the way, but I'm hopeful that we can get to that point within New Jersey, because there are other states that are more along that pathway for good and bad, right? I'm not going to say it's always perfect, right? Than in New Jersey. And I think that's a huge opportunity for our state.
Thanks so much. I think we could probably be continuing this conversation for hours more, and it certainly has been a tremendously informative for me to get to moderate this panel, and I think for all of our members. And I'm sorry to cut off the conversation, but hope it's one we can continue at our next Quality Institute event. But I want to say thank you so much to all of you for sharing your rich history, for giving your present and future vision of what primary care looks like. I think it certainly makes me hopeful for the work that we have going forward in the next year. It also reminds me that I need to make my primary care appointment. And certainly, if nothing else, I hope it's reminded the many members who are on here to make that appointment in the new year. I'm going to turn it back over to Linda to give us some final thoughts about today.
Thanks, Kate. And please, all of our panelists, stay on. I want to thank you all for your enthusiasm and your commitment, and for being primary care family physicians and here to take care of all of us. So thank you for that. In my vision for 10 years, you'll all still be practicing, and many other people will as well, because somebody has to take care of all of us. And my primary care physician's on my iPhone right here, which I really, really like that function. And I think my generation does too. So that's my vision. But as we wrap up, I want to, again, thank all of you, thank Professor Hudson, thank everyone who contributed to our action plan. And particularly, I'd like to thank the Robert Wood Johnson Foundation for supporting our conference today, as well as part 2, which will take place February 23rd. And I want to wish all of you a very happy, safe holiday. Our part 2 will be virtual, just to clarify, but we are really looking forward to having some in-person events in 2022, and which is why we all need to get boosted and get our flu shots. Anything else I should say, primary care physicians? No, but anyway, thank you all, and have a wonderful new year, and we'll see you in 2022. Thanks. Bye-bye.
Thank you, everybody.